Hi, my name is Elizabeth King. I am the Senior Manager of Cancer Risk Counseling here at City of Hope. I am a nurse practitioner and I have some additional credentialing certifications in oncology and in genetics. And today we're going to be talking about clinical oncology. And I have no disclosures to report. So learning objectives today, we're going to talk about the basic mechanisms of cancer development. We will talk about how cancer is diagnosed and staged, and we will review how cancer is treated. And so looking at the mechanisms of cancer development, let's talk with just about some general statistics. So we know that cancer is a very common disease. Approximately 1 in 3 people will have cancer in their lifetime. That's here in the United States as of 2019. And if we break that down further, you can see kind of facts and figures from 2019 again. So prostate cancer being the most common cancer in men. In women, the most common cancer is breast cancer. And so you could see our range here from kind of prostate to pancreas. We hear a lot of people being really nervous about pancreas cancer, right? But it's a fairly rare cancer comparatively. So our top 3 for men are prostate, lung, and colon. And for women, that would be breast, lung, and colon. And then if we flip it and we look at deaths, right? So what are people actually dying from? So we looked at what are the more common cancers, but what are actually causing the cancer deaths? And so in men, lung, actually in men and women, right? We see that lung causes the most cancer deaths. And that has to do with screening. We only recently have kind of developed better screening, but there's a lot of people who are not doing that screening, right? So we tend to catch it later. And kind of second most common cause of cancer death in men is prostate and then colon cancer. For women, lung again is number 1, then breast, and then colon. And so what are risk factors for cancer? So really the biggest one is age. So the older you are, the more likely you are to get cancer. So we see that kind of the 65 to 74 range tends to be kind of the sweet spot for cancer. The median age of diagnosis of cancer in this country is 66. Also, lots of modifiable risks for cancer, right? So these are the things that we and that our patients can change and can control. So the biggest modifiable risk for cancer is tobacco use. So when we think about what is the relative contribution to cancer incidence, we see that tobacco use is absolutely the highest. And then the next highest is obesity. So I think there was a big PR push. Everybody knows that tobacco causes cancer. I think a lot of people don't know that obesity causes cancer. And that's a complex one. We're not completely sure why that is. There's, some ideas. Is there hormonal involvement? Is there diet involvement? Is it lack of physical activity? Likely it's sort of all of those things mixed in. And then our kind of third most common or sort of biggest contributor as far as modifiable risk factors are pathogens, right? So HPV is a big one. So while tobacco used to be the leading cause of head and neck cancers, it's now HPV. But we also see obviously cervical cancers, we see vulvar cancers, we see anal cancers, but also hepatitis, right? Epstein-Barr, there's lots of pathogens that potentially cause cancers. And really, what is cancer? So cancer is a disease in which a group of abnormal cells grow uncontrollably by disregarding the normal rules of cell division, right? And if we look at that kind of more closely, we know that as our cells divide, they have 20,000 plus genes every time they divide that they have to make a copy of. And so they're going to make mistakes, right? We have lots of cells. There are going to be mistakes made. And so fortunately, there's kind of backup mechanisms, right? So a cell may divide. It may have a mutation in an important gene, but it's probably still fine because of the backup mechanisms, right? And as that particular cell now is dividing, it may develop another mutation, right? And as that cell is dividing, it may develop a third mutation. and then a fourth mutation, and then a fifth mutation. And so you can see why it makes sense that just for that to happen, that it's doesn't happen all the time, right? Which is why only 1 in 3 people will get a cancer in their lifetime. But B, also that it just takes a long time to happen, right? Which is why we tend to see cancer in older people. And when we think about kind of the main types of cancers, most of what we see are carcinomas. So carcinomas are cancers that begin in primarily kind of in epithelial cells, right? So lung cancer, breast cancer, those are kind of common carcinomas. Sarcomas, on the other hand, are cancers that that begin in the bone, cartilage, fat, muscle, blood vessels, just kind of our supportive tissue, right? So you hear about like osteosarcoma, or sarcoma, kind of muscular sarcomas as well. And then leukemias start typically in the bone marrow, right? So that's a type of blood cancer. And then the lymphomas, and multiple myeloma kind of falls in this as well, are cancers that begin in the cells of the immune system. And as we think about cancer diagnosis and staging, we'll kind of move into that section next. And our initial presentation is sometimes found on routine screening, right? So mammograms, colonoscopies, right? PSAs, those sort of things. Or sometimes we will pick it up in a history, right? If somebody presents for their regular physical exam and they say, hey, by the way, I've had unintentional weight loss and I've been having night sweats, then that's not something we necessarily see on an exam, but it's something that somebody's reporting to us that makes us suspicious of perhaps a lymphoma. And sometimes we'll pick up an abnormality on a physical exam, right? So we might find a breast mass or a head and neck mass that we see on a physical exam. Or we see something in incidental findings. I personally had a patient who had a chest x-ray because she had a cough, and then it picked up a big renal mass that ended up being kidney cancer. So lots of different ways for cancer to present originally. And a thing that we say a lot in oncology is tissue is the issue. So a cancer diagnosis is really made by pathology. So you can have a physical exam, you can have a history that is suspicious, but really we need pathology and we need a biopsy to confirm a diagnosis. And that's going to tell us a lot of stuff, right? So that's going to tell us, is it cancer, right? Or is there a benign mass, right? Some cells that are kind of overgrown, but are not necessarily going to metastasize or go anywhere else. It's also going to help us understand what type of cancer is it. We know that particularly sort of in the head and neck and kind of in the cervical area, that could be lots of different types of cancer, right? Could that be an oral cancer? Could that be a breast cancer maybe that has moved up into those lymph nodes? Could that be a lymphoma, right? So we need to be able to, the pathologist needs to be able to look at that slide and make a differentiation as to what type of cancer it is. We also need to know, is this a new cancer, right? Is this a recurrence of a previous cancer? Is this metastatic disease? So, for example, if somebody presents with a liver mass, you will hear sometimes people say, oh, I had liver cancer, I had breast cancer and I had liver cancer. Liver cancer happens, but it's not a particularly common cancer. What is common is a breast cancer that metastasizes to the liver. So what we need to do is go in there and get some cells from the liver and look at them on a slide. Do those look like breast cells or liver cells, right? And something that you'll hear a lot, particularly as you're sort of collecting family history, you'll hear lots of bone cancers, right? When we say bone cancer in oncology, we typically mean osteosarcoma. Again, an incredibly rare cancer. So the number of times you're going to hear it is not going to correlate to the number, how often it actually happens in the population. And so bone cancer probably means, like, did they have a lung cancer first, right? Did they have a breast cancer first? And did it metastasize to that area? Or are they calling a leukemia bone cancer, right? Because that maybe came from the bone marrow. And then sometimes it's a little bit hard to differentiate. Is this a new primary tumor or a recurrence, right? In somebody who's already had cancer. And so one of the ways you can sort of look at that is it on the contralateral side? So for example, in breast cancer, if the patient originally presented with a left breast cancer and now has a right breast cancer, right? That's the contralateral side. That's not the same cancer, right? That's a brand new primary cancer. But what if it's on the ipsilateral side, right? What if it's on the same side as the original cancer? So you got to do a little digging because at that point, then you can compare pathology, right? And say, are these the same cancers? Do the molecular markers line up? Or did this person develop two primary cancers, right? Two brand new cancers in the same breast, because those are both possible. So the other things we'll get from pathology is we will look at sort of how aggressive is the cancer. We can often pick that up from a biopsy, and then potentially if it's spread. And cancer cells look very different from normal cells if you compare them side to side on a slide. So cancer cells, there's just a lot of them, right? And that makes sense because they're not doing their job of being a breast cell anymore or being a lung cell anymore, right? They're just kind of dividing out of control. So there's just a lot of them. And they end up tending to look a little wonky. They've got kind of their nuclei look different. Their cytoplasmic volume gets smaller. And they're really variable kind of in cell size and shape, right? Because again, they're not doing their normal job of whatever they're supposed to be doing. And they can lose those kind of specialized cell features. It just looks disorganized. You can compare a slide that's, skin is a good example. You've seen the kind of diagrams of skin where there's just very clear layers of the different types of skin cells. And when it's a skin cancer, it's just kind of a mess. It's just kind of all over the place. And there's also, I think there's this idea that tumors, are just kind of like circles, but they're not, right? The cells are just kind of dividing out of control. They end up sort of with fingers. They branch out everywhere. So there's often not a very clearly defined tumor boundary. And one of the ways, once we have that pathology, we are able to start talking about grading. And so grading is a description of a tumor based on how abnormal the cells look, right? So do they look more like that original breast cell? Or do they look like a completely undifferentiated cell? And so remember, we all started off as one cell. We all started off as just one stem cell. And that one stem cell ultimately turned into very specialized cells that are doing specialized work, right? So breast cells, liver cells, heart cells, right? Colon cells. And they look very different now. As a breast cell or colon cell starts to get more aggressive, it loses the characteristics associated with that original cell. So it looks less like a breast cell and it looks more like a stem cell, right? So we call that undifferentiated. It doesn't look different anymore. It just looks like kind of a generic cell. And so the more a cell gets to that point, right, and it gets more and more undifferentiated, we consider that a higher grade. And that tells us that the cancer is more aggressive at that point, that it's more advanced. Those cancers tend to grow and spread at a faster rate than the cells that are better, that are well differentiated. Now, staging we think about more as sort of where is the cancer in sort of relation to the original primary. And so what this is kind of how patients use these terms. In oncology, we tend to use a different system that I'll talk about a little bit. But patients, you will say, I was stage 1, I was stage 2, I was stage 3, right? And this is important to know, right? Because it tells us sort of what the person's potentially prognosis is, tells us about treatment. It also may tell us what genetic testing that patient qualifies for. But stage 4 typically means that the cancer has spread to other parts of the body. I will mention here that different types of cancer have different staging systems. This is just sort of a generic kind of overall, and the same for grading. Grading is a little bit different for prostate cancer, for example, but these are just sort of generic. This is sort of generally how we think of cancer. So stage 4 tells us it's metastatic. It's generally spread to other parts of the body. Stage 0 is usually kind of an in situ cancer, right? So it's still sort of where kind of in its little capsule. And then stage 1, 2, and 3 are in between, right? And it has to do with size and nodes and that sort of thing. Potentially still curable at that point, though. And then in oncology, we use, for most cancers, we use this T&M staging system. And so we think about T is based on the extent of the primary tumor. N is absence or presence of regional lymph nodes, right? So the lymph nodes that are just kind of close by, right? Versus M is either the absence or presence of distance metastasis, right? So is it sort of further away from the primary site? And so this adorable, I've got the watermark in there because this is how he presents it. He says that we can all share it, but he has these fun little drawings of different things. This was the one cancer drawing he had. But I think this is a good example when we think about cancers, because that for prostate cancer, you can see kind of the T staging here, right? So like a T2A lesion is pretty small, and it's just sort of in one side of the prostate. And then you can see sort of it gets bigger when we get to 2B and 2C. Then when you get to 3, you're sort of kind of edging out of the prostate. And then when you get to 4, then you're quite a bit out of the prostate. And then we again look at those regional nodes, right? So the nodes kind of in the area of the prostate. And this is, of course, true for all cancers. If there are no nodes, it's an N0. If there are nodes, if there's one node, it's an N1. And then again, we sort of look at metastatic disease. So is there zero metastatic disease, or is there, kind of where is it sort of physically in the body? And then we'll move into treating cancer. So they say that laughter is the best medicine unless you have cancer, in which chemotherapy is more effective. So when we think about cancer treatment, it's really important to consider what are our goals? What are the goals of treatment? And part of the way that we do that is we think about what is the cancer, kind of what is the extent of the cancer diagnosis? Is this somebody who's metastatic, right? Or is this somebody who has a stage 1, an early stage cancer? We also have to consider what are their comorbidities, right? Is this somebody who's very sick? Is this somebody who has heart failure, right? And they have a very low ejection fraction. Well, maybe that's not somebody who's appropriate for chemotherapy. We think about the age of the patient. Then we think about their performance status. We think about what are their prior treatments. Have we beaten them up a whole lot with chemotherapy over the years? Or are they kind of younger and stronger? We also think about their support systems and their resources. How hard is it for them to get to treatment? If they live very far away from a cancer center, or they don't have a car, it's really hard to ask them to come in and do radiation 5 times a week for 6 weeks or whatever the case is. And so those are all things that go into consideration when we think about cancer treatment. But we think about, so how do we think about our goals? We think about cure. Right. So there are patients who we go in expecting a cure, right? Whether that's surgery, whether that's chemotherapy. It doesn't happen every time, even when we're hopeful. But we sort of manage that patient as if we are with intent to cure. We also think about control. So sometimes we will find metastatic disease that is maybe not particularly symptomatic. And that patient wants to just, kind of live as long as they can with good quality of life. And so we just need to control their disease. And you'll hear people talk about cancer has turned into a chronic disease. So it's not necessarily the death sentence it used to be, right? So in the same way that we treat diabetes or that we treat hypertension, we treat cancer. And as particularly in, metastatic breast cancers that are ER positive, tend to be less aggressive. And those folks can live a really long time. But we need to control their cancer. We also think about prophylaxis, right? So our same kind of surgical and medication-driven treatments that we use in cancer, we will also sometimes use for prophylaxis, either in someone who has never had cancer, right? When we think about, for example, a BSO in somebody who has a BRCA mutation, or we think about it in, for example, a woman who has breast cancer. Maybe she opts to have a bilateral mastectomy instead of a single mastectomy, right? So that's to treat her current cancer, but also to prevent cancer in the other breast. And then palliation. And so there are absolutely patients who present with disease that is painful to them or causing shortness of breath. And so how do we treat them in a way to relieve their symptoms? And that's not somebody that we're necessarily trying to extend their life. We're definitely not trying to control or cure it, right? We're trying to make them feel better. And so lots of things to sort of think about. If you see a patient who is on chemotherapy, that's not necessarily somebody who's going to be cured. It's not necessarily someone who's going to live a long time, but it could be, right? So I think looking at staging, looking at grading, thinking about the comorbidities, and having a good understanding of what are we doing here? What are our actual goals of treatment? And lots of different ways to treat cancer. Hormone therapy, really, really common in prostate cancer and breast cancer. We know that those cancers tend to have hormone receptors. So if we block those receptors, then we keep those growth factors from getting in the cell. So oftentimes that doesn't necessarily kill the cancer, but certainly slows the growth or stops the growth. And if we stop the growth, maybe that cell will die and we won't, it will at least be able to control it. Obviously, we can use hormone therapy as prophylaxis as well. Surgery, obviously, if we take the cancer out, right, then that's can again provide palliation, that can provide control, that can provide cure. Bone marrow transplant, similar probably to surgery in the way that we're sort of removing the cancer from the body, but we're putting in something else, right? So that could be either blood that from the original patient that was treated, and we hope we got rid of all the cancer, or from a donor. Chemotherapy is one of the mainstays of cancer treatment. Chemotherapy works by sort of targeting cells that are rapidly dividing. And that makes sense, right? Because a lot of our cells, while they're dividing, some of our cells are dividing, some of them are not. Some of them are just hanging out doing their job, right? They're being lung cells or heart cells or pancreas cells. But there are cells who are rapidly dividing, and there's a good way for the chemotherapy works to target those cells. And so often we use multiple drugs. And the reason that we do that is because we can get to the cells in different cells of this cell cycle, right? And so then we sort of maximize kind of cell kill, but it also decreases our risk of drug resistance. And then our more targeted therapies, so, certainly precision medicine is sort of all the buzz right now. And so we can use more targeted therapy. We can look at a patient's tumor and say, okay, here are the mutations. Can we use some particular medication that targets that, right? That specific change to your cancer. Radiation therapy causes DNA damage. Often radiation therapy is combined with chemotherapy. And then immunotherapy, of course, works to turn on the immune system so the immune system can go in and attack the cancer. And of course, all of these treatments have side effects, right? So radiation therapy, for example, is going to take out some normal tissue as well, as is chemotherapy, as is immunotherapy. There's unfortunately not a super clean way to give these where it only attacks the cancer. And that's why, again, we have to think about what are our goals of treatment, and what is the patient who's sitting in front of us, what do they look like, and what do they want out of this treatment. And then just want to talk just briefly about survivorship. And so when we think about cancer treatments, cancer treatment isn't done when patient gets their last dose of chemotherapy. There is estimated 14 million people in the United States who are cancer survivors. And by 2025, we expect that to be 24 million. And so, we really like to think about what do these cancer survivors need? Cancer survivors historically, we see them for their last dose of chemotherapy, and then we say, okay, cool, see you later, see you in 3 months. And these are people who were being seen every week. They were getting lab work, they were getting physical exams, and then all of a sudden we just let them go. And it's been compared to if you saved somebody from drowning, and then you said, okay, see you later. And they said, but wait, I'm cold and I'm wet and I am freaked out and I need a ride home. I was like, nope, I saved your life. I'm done. And so I think really thinking about cancer survivors in a different way has become kind of a more common, unfortunately, kind of brought to the forefront. And so part of that is, how do we prevent future cancers, right? And we talked about what are the modifiable risks of cancer, right? So tobacco is a big one. So I can't tell you how many people I've had come in with lung cancer who are still smoking. Smoking is incredibly addictive. So how do we help them to quit smoking, right? How do we talk to them about diet and physical activity? Those are things we have to talk about. We have to talk about obesity. How do we get people? And it's different for everybody, right? Like, what do they have available at their grocery store? Do they live in a safe neighborhood where they can walk? Or is there somewhere close by where we can look into free gym memberships? And then we talk about kind of follow-up care. And screening, right? So depending on the type of cancer and depending on the stage, we will sometimes sort of screen people closely for, some limited amount of time for recurrence of their cancer. Or we say, you know what, we're pretty sure we got rid of that cancer, but we need to keep an eye out for future cancers. And so thinking about that, kind of cancer screening, or even brand new, like completely different cancers, right? If somebody had ovarian cancer, for example, and we were able to cure that, we don't want them to show up with metastatic breast cancer later, right? So they still need to do their mammograms. But we also kind of think about families in that way. Families also need screening for cancer. And then we also talk about kind of late management and side effects. So oftentimes after chemotherapy or after radiation, sometimes people will have sort of chronic issues. They will have issues with cognitive function. We'll hear that called chemo brain, or they'll have issues with sexual function, right? So somebody who's had a prostatectomy, or even a breast cancer survivor who has body image issues. Sometimes people can have long-term pain. So there are particular types of chemotherapy that cause nerve damage, and people can have chronic pain in their fingers or toes because of that. We also see kind of psychological effects, right? So people will sometimes compare cancer treatments to our kids that go off to war, and they say, you know what, you put your head down and you push through, but then on the end of it, that's when you have to sort of cope with all of the stuff that just happened. You just went through this terrible kind of life-changing experience. So depression, anxiety, all of those things need to be addressed as well. And so really just kind of this idea that clinical oncology really is a continuum, and it starts from that sort of initial presentation and initial diagnosis into making treatment decisions, right? Which is, should be a discussion between the patient and their providers, kind of getting into active treatment, and then into survivorship. And that sort of transition, right, from going from a cancer patient to a cancer survivor, and then that kind of long-term cancer survivorship. And so really in clinical oncology, we should be, bridging this gap and providing support throughout the entire process. And that's all I have for you. Thank you very much.